So welcome to the Cerebral ALD Bootcamp. Both Troy Lund and myself, Florian Eichler, are delighted to be here. And Troy will kick it off by talking about transplant and his experience and understanding of the state of the art today. Troy?
All right, thanks. Am I coming out okay on the audio?
Yep, we can hear you.
Okay, and then I'll just read our typical disclosure for webinars, that the webinar is for informational purposes only. The discussion is not intended to be a substitute for professional medical advice, diagnosis, or treatment. If you or a family member are ill or suspect you are ill, seek professional medical attention immediately. ALD Connect does not recommend or endorse any specific physicians, treatments, procedures, or products, even though they may be mentioned on this webinar. All right. And then I will share screen and share. All right, hopefully the screen should show my PowerPoint, is that correct? Florian nods, yes. All right, well, I don't have a lot of slides. It's really more of a nuts and bolts about ALD, cerebral disease, and the types of transplant, and then one slide on kind of gene therapy. So I'm trying to figure out, what families really want to know, and the questions that I get asked a lot. Let's advance. All right, so I show this slide a lot, which is the goal of transplant, and which is the resolution of cerebral disease. And as a reminder, this is a gadolinium enhancing brain lesion, and the child on the left there, you can see the rim of gadolinium in this kind of white semicircular area here. This is abnormal. This is really the inflammation that accompanies cerebral disease. And so that needs to go away because that's part of the destructive process of cerebral ALD. And the middle image here shows the same brain 28 days post-transplant, and that's completely gone. And in this case, it's gone and has never returned. And so that really is the extinguishment of the active disease process in cerebral ALD, which is the entire goal. Now, I always have to comment that on the imaging for children with cerebral disease, there's the other type of imaging that shows us kind of the injury and the demyelination, and that's we call T2 imaging technically. But when you look at those images, this is where we get our less score that everybody talks about. That's really the injury of cerebral disease. And on the right, this is a boy's scan a year after transplant. So that doesn't go away. That injury and the picture of the injury stays. But again, the goal is to get rid of the active inflammatory process and make sure this injury doesn't spread any further, or at least slows to almost an imperceptible extent. And so we talk about that a lot. There's a lot of confusion around that when we go through MRIs with the families. But again, the injury that's obtained generally stays. The active part of the cerebral disease process is really what we're treating with these types of transplants. So I have a couple of slides on survival curves post-transplant that have pretty much remained unchanged through the decades. This is really a survival curve. Years is on the bottom axis, the proportion is on the y-axis, Everyone starts at 100%. This shows the survival curve based on the extent of disease, or based on, in this case, choice of stem cell source. And, you know, in our world, the related donor is the sibling donor. We have excellent outcomes at 100% survival. Anything less than that, less than related donor, has less than 100% survival, so 80 to 90%. Showing, demonstrating, like in all fields in transplant, matched sibling donors are first choice. On the right shows the impact of N-acetylcysteine. I don't show or talk about it a lot, but it's something I get asked about. It is a potent antioxidant. We were able to analyze our data in very advanced kids who were on N-acetylcysteine through transplant, and those without. And those without had very poor survival. Those on it had better survival. But I can tell you, if you look at you know, the graph in D, it says less score greater than equal to 10. So these kids are all fairly advanced. Does it impact kids that are less advanced? I'm not entirely sure that they need N-acetylcysteine. We do use it in some of our regimens, but those kids are in such good shape these days, coming in with less scores of 1, 2, 3, 4, or whatever, that you know, when we looked at the benefit of N-acetylcysteine, it was truly beneficial in the very advanced patients, of which prior they didn't have many choices. So this is the impact of disease and less score. So again, survival with a less score of less than 10 is excellent, 90% and higher. And again, the boys that are greater than or equal to 10 have inferior survival. There is a cutoff for us where we don't offer transplant. It's somewhere north of a less score of 12 to 13, but does depend on the individual child and their symptomatology as well as other factors. But it does just show you that the impact of disease is extremely important in survival after transplant. Hopefully, as my practice moves forward and newborn screening moves forward, you know, I won't be seeing kids with less scores over 10 anymore. Though at this time they still show up. So again, impact of disease and transplant survival. Now, briefly, what types of transplants are there? There's all sorts of different terms: hematopoietic stem cell transplant, bone marrow transplant, stem cell transplant, umbilical cord blood transplant. These 4 things are all interchangeable. Then there's gene therapy. This is also a transplant. It's a hematopoietic stem cell transplant, in fact. So those are the names that get thrown out and are often very confusing. The types of transplants are autologous gene therapy, that Florian will talk about. There's then allogeneic transplant, which means not self. So that can be a related, like a sibling, or it can be an unrelated person, like someone out in the country or in the world just that matches the individual through HLA matching, which I can talk about later. The allogeneic transplants can be matched. We call, when we use our matching algorithms to look at various proteins, you can be 100% match or perfectly matched. And there's also mismatches that are allowed in some transplant settings, particularly in umbilical cord blood. You can have a mismatched transplant and still do excellent. And then the other terms we talk about are where the cells come from. UCB is an umbilical cord blood. That's there's a national bank with over 1 million units ready for transplant for any disease that is stored. There are also peripheral blood stem cells, which we don't use as much in children. And then there's the classic bone marrow stem cells or bone marrow transplant. So you can have a mismatched, unrelated umbilical cord blood transplant as an example of how to put this all together. Or you can have a related, perfectly matched by definition marrow transplant. And then there's this obscure type of transplant called syngeneic, which is twin to twin, which is not done in this setting or in many settings for that matter. So I'm going to talk then about three more things: the workup, the LESS score, neurologic function score, and then risks and benefits. So first, a bit on the scoring system that was developed by Dan Less with our colleagues at Kennedy Krieger a number of years ago. There's so much discussion about it. And one of the most confusing point is that a larger score means more brain, and it doesn't really work that way. It's really brain structures and its number of structures. And while there's an association that a higher score means more brain, it's not necessarily 1-to-1. You can have a large amount of brain involved and have a low score because it's really built on numbers of brain structures. So it requires a detailed knowledge of neuroanatomy to count those structures. And I've given you 4 examples here along the bottom. The first one on the left is a child with a LESS score 1. He has a little bit of brainstem involvement. These little 2 white areas here. And then there's a child next to them is more classically kind of a cerebral disease picture, is a score of 1.5. He has corpus callosum involvement, which is this white area here. It goes off to one side, as you can see, more or less. And score is 1.5, but it's not like the lesion is 50% bigger compared to the 1. It's a different area. The next child is a score of 3. Again, a little bit more extensive involvement, but it's not like he's double of the 1.5. Again, it's numbers of brain structures, and I'm not going to go through all the neuroanatomy to show you all the structures. And then here on the far right, the score is 7. And again, he's, to the casual viewer, it's not like he's much more than a 3, just looking at the spatial imaging. So again, to alleviate some of the confusion, we're counting parts of brain. We're not counting square centimeters. And why is this child of 7? If you look here in the midbrain region, he's got other areas involved here and here. So that's why he got points added to his score and why he's a 7. So hopefully, as I continue to give similar talks and talk about it, I'll probably never solve all the questions about the scoring system, but it's one of the major points that people get confused about. So that's the score. I did want to touch on the workup. When I refer to a child either with cerebral disease or without cerebral disease, what we do is we put the child through a battery of tests. Usually takes 3 to 4 days. We assess their disease status, and part of that is knowing the score. How much, what's areas of the brain involved. What is the neurologic function score, which I'll show you in a second. What are his other symptoms? Perhaps the child has ADD, ADHD, or psychiatric diagnoses. I pay attention to protein markers in the spinal fluid, and then there are other factors that go into our overall assessment of disease status. So that's one large area we look at prior to bone marrow transplant. We do HLA matching to find suitable donors. Brothers and sisters are first choices because they're either perfectly matched or they're not. Other than that, we will look at all the databases around the world for cord blood or unrelated persons that might match the child. Within those few days prior to transplant, there's assessment of really all the organ system of the child. We check out the heart using echoes and EKGs. We check out the lungs. We use CTs, make sure they don't have infections. We check out the kidneys. We take good health history. We check their blood for immunity to past infections. This is all part of the workup of a child heading into transplant. And often that decision has already been made when we're at this stage. It's a child who has known cerebral disease, and we need to employ transplant as the therapeutic maneuver. And this is the same is true for gene therapy as well. It's the exact same workup. So all the same tests are ordered. And then we look at other risk factors, which might include underlying lung disease, underlying other genetic problems, which can happen rarely, any other processes. A few kids we've seen have diabetes, a few kids have other lung diseases, or things of that nature. I did want to just touch on, I explained the LESS score. I wanted to explain NFS in here. So just so that you've seen it. So NFS is neurologic function score. Somebody with no problems is a score of 0. Once you start having neurologic problems, the points get added. So higher scores are worse, just like in the LESS score. So if the child's having hearing processing problems at the point, loss of communication is 3 points plus these other 2, which is a total of 5. If the child is having visual problems, that's 1. If they're blind, they get 2 points plus the 1. Tube feeding is 2 points, though we rarely see that now in new patient visits. Running problems, gait problems, wheelchairs, these all add points. We use the scale pre-transplant, and then we use the scale following transplant to track patients to see how they're progressing neurologically. So that's the neurologic function score that was developed by Jerry Raymond and Dr. Charnas a number of years ago. I did add a slide on just process. The process prior to transplant is a central line is placed 1 day prior to chemotherapy. In the child, this allows delivery of the chemotherapy in the stem cells. This is followed by 6 to 8 days of chemotherapy in the hospital. Day 0 is what we call our transplant day. Then there's the recovery of the immune system, which occurs in a hospital. It takes 14 to 28 days. And that depends if you have gene therapy or sibling or a cord blood transplant. It's during this period we have side effects such as hair loss, mucositis, fevers, nausea, etc. You can also get infections. Things can get very serious during this period of time. You can have the onset of GVHD in this period of time and later as well, etc. Once you're discharged from the hospital, everybody comes to clinic every day for the first 2-3 days, and then you go to every other day, then every third day, and on and on and on until you're coming once a week, twice a week, assuming no complications. Usually we send children back home to their home physicians or institution by day 60 for gene therapy, and often by day 100 for any other type of transplant. Then they return to our center every 6 months for MRIs and assessments. Any complications in the child after gene therapy or allo transplant changes this entire calendar. So this is really the perfect course. And then I just have one other slide because I get a lot of questions about gene therapy and allogeneic transplants. So as the questions have come in over the years, I've tried to really just lay down what I think the differences and similarities are. I never commit to what is better or what is worse. Every patient is assessed as an individual. And so we try to find the best therapy for each patient. So I often won't use what is the best medicine for my child. But hopefully a slide like this just it simply puts down on paper, you know, what are some of the similarities? And there are more similarities than there are differences. You know, they both have chemotherapy. The cells involved are self cells for gene therapy, non-self for any other transplant. The recovery is a little faster with gene therapy because it's your own cells. And so that transplant always recovers faster. It's a little slower for any other type of transplant. There's no GVH for gene therapy. It's just not feasible. In allo, there's a rate of about 10 to 15% of mild GVH. We haven't gotten rid of it yet. Most of it's treatable. Progression possibility, sure, there's always a possibility with gene therapy, and it's also a possibility with other types of transplant. The gene correction given by our published Gene therapy results show 15 to 40%. As I tell families, with a donor, it's always 100%. Unless you use a sibling who's a carrier, then it's 50%. The durability in gene therapy is unknown. That is, how long will it last? In allogeneic, there have never been any relapses to my knowledge after transplant with an allo donor. Risk of cancer for chemotherapy, you're getting busulfan in both of these treatments. There's a risk of skin cancer later in life. It's the same in both. Risk of cancer from the gene insertion. Gene therapy involves the random insertion of a gene into your genome, so there's going to be a risk of cancer from the process, no matter how safe it is. Today's gene therapy is as safe as possible, and that has evolved through many generations of gene therapies over the last 3 decades. In allo, we don't have any gene therapy, so there's no risk of that. Fertility issues, yep, you're getting high doses of busulfan. Most males will have reproductive problems later in life because of the busulfan. We've not gotten away from that. Overall risk from the therapy. Gene therapy is an auto transplant using your own cells. I'd have to say the risk of death from the therapy is going to be lower just because of that easier process. And it's probably going to be higher when you use somebody else's cells. And that's really just a synthesis of everything about transplant that we know. Risk of AMN later in life, I just couldn't tell you with gene therapy. And allo, I have to say possibly. It's been reported in at least a couple of patients, so I can't say it's zero. It's not well studied, but I have to say possibly. Practical things, when does that central line come out of the child? In gene therapy, it's out of day 60 in the allo transplant setting because you're getting labs, checking blood draws, and checking drug levels. It's day 180, so it's a longer period of time. And then there's cost. Gene therapy is estimated at $2.5 million, and allogeneic transplant, depending on the center, can be $400,000, $800,000, or it could be a little bit more. So this is more of a kind of a black and white presentation of what I get the most common questions on, and that I think is my last slide. And so I think Florian will talk kind of in detail about the gene therapy study that's been going on for about 5 or 6 years now and the promise it brings for the future. So I'm going to stop sharing.
Thanks, Troy. That was a very nice and clear overview. So as you said, I will try to connect to the themes that you raised and go a little bit more into depth regarding gene therapy for childhood cerebral ALD, and also talk a little bit about new gene therapy modalities that might be coming in the future. Here are my disclosures. So I thought I would start off by just adding a little bit to the language of people who might be new to understanding gene therapy. When we use the term gene therapy, there actually are different modalities that we're talking about. Most of what Dr. Lund and also the field of childhood cerebral ALD has seen to date is what we call ex vivo gene therapy, which is lentiviral mediated, which is based on harvesting of cells from the body and transfecting those cells with a therapeutic gene and then giving those cells back. That's a cell-based delivery modality. In contrast to in vivo gene therapy, which is a direct delivery of the therapeutic gene and is AAV mediated and usually is directly inserted into the target organ, whether it's the liver, whether it's the spinal fluid, and these modalities are now becoming more and more common across various trials. But just to point out that gene therapy in of itself is not one thing. There are various different delivery methods and approaches depending on the disease and the type of pathology and where it's located. So as I mentioned before, in vivo delivery necessitates direct delivery locally. Often this is directly into the brain, as we have now a few trials that are now employing AAVs to directly inject into the brain, or intrathecally, similar as to when you get spinal fluid. Just in this case, instead of only pulling it off spinal fluid, you're now injecting the AAV carrying the therapeutic gene. And in some cases, there are also trials that are intravenous, as with the first successful AAV gene therapy for SMA, which was done intravenously directly into blood. Often when we talk about neurologic disorders, we really want to know what structures are affected, and we're targeting that with AAV gene therapy, whether it's in Parkinson's, Huntington's, or also in lysosomal storage disease, where we have the advantage of cross-correction, which may not be the case here in ALD. So how does this differ from ex vivo gene therapy, and particularly important now for cerebral ALD? Here we are taking hematopoietic stem cells, very similar to a bone marrow transplant, but transfecting them outside of the body with a lentiviral vector. And we think this helps the brain because the cells we are transducing are precursor cells to a certain cell type in the brain, namely the microglia. Whether that's the only way that this gene therapy is beneficial, we don't know, but it is certainly one possible modality. Another difference between in vivo and ex vivo gene therapy is that in ex vivo gene therapy, you have something called hematopoietic reconstitution. It's a fancy word, but what it means in short is that you now have a lifelong source of this therapeutic protein and corrected gene being made, as opposed to in vivo gene therapy, which is a one-time administration of the AAV with the gene. So just briefly, I'm going to summarize the single-arm phase 2/3 study in ALD that just was completed, and very exciting. Yesterday, the EMA granted marketing approval for this modality in Europe. So this is has now become an approved therapy. This all started, as Dr. Lund mentioned, about 10, 15 years ago, where we really built on the successes described on bone marrow transplantation. So all this could not have been possible without the insights coming from the transplant field. We used exactly the same enrollment criteria that are used for bone marrow transplantation, namely that it had to be active cerebral disease with contrast and enhancement. Early stage disease, as Dr. Lund described, was required, but different from the transplant scenario. We initially excluded patients who had matched sibling donors, since we thought in the first phase of the study they would do better with a bone marrow transplant. In the meantime, this was abandoned, and we also now include matched patients who have matched sibling donors. So we looked at this over a 2-year period, examined them for changes in LES score and NFS. I won't go into detail here since this was already described, but just to mention again, our greatest concern was that we wanted to make sure this was done safely and that there was no insertional oncogenesis seen, which to date we have not seen any development of cancer in this trial, and are keeping a close eye on this. So just a brief overview of the treatment protocol to date. How is gene therapy being performed? We harvest cells from the boys themselves and then transfect them with a lentiviral vector carrying a healthy copy of the transgene. And then after transfection of these cells, we deliver them back to the boys. We give them a brief amount of chemotherapy, either with busulfan and cyclophosphamide or busulfan and fludarabine. And then we follow them over a 2-year period. Important to mention that all of this is very similar to what happens in a conventional bone marrow transplantation, with the exception that we're using cells from the boys themselves, so autologous cells, not cells from a foreign donor, okay? So that is the major difference between the two modalities. Similar as to after conventional bone marrow transplantation, we looked at changes in neurologic function score and MR imaging over time. And just to mention here again what has been seen and presented in the past, namely that most of the large majority of the boys stabilized in their neurologic progression and their symptoms immediately after treatment. There was one boy who was already progressing quickly at the time of treatment, and where we really came too late, and he succumbed to disease progression that happened very quickly after the treatment. There were 2 other boys who then dropped out of the study after there was some contrast enhancement seen, but all the others here, in the meantime, more than 50 boys treated, about 90% of them have stable neurologic course. On the less scores, what we see is about half of the boys stabilize in their MRI lesions immediately after treatment. The other half progress to about 12 months and then start to stabilize. Just to mention the kind of imaging changes that we're seeing, as Dr. Lund mentioned, we see contrast enhancement go away in all of the boys by 6 months. What happens with ex vivo gene therapy, as opposed to what is seen under conventional bone marrow transplantation, is that you see this occasional flickering of contrast. And I put a few examples here to show what that actually means. At screening, you see clear contrast enhancement in a well-demarcated fashion that goes away after infusion of gene therapy. But in some cases, you then see a little bit of an emergence of some diffuse and scant contrast, but very different in nature than what you see in the untreated condition. And when you follow that up, it usually disappears again, but it does make us nervous and makes us wonder whether we are transducing enough cells. And we are seeing now less of that as we've increased vector copy number in drug product over time. So at the time of the Child Neurology Society last year, I reported 45 boys with early stage cerebral ALD having gone through this ex vivo gene therapy. Now we are above 50, and at 2 years, 87% of these patients were alive and free of major functional disabilities. The kinds of adverse events we saw were very consistent with what is seen under conventional bone marrow transplant, namely fevers, transient vomiting, some bladder infections, but no graft versus host disease, no graft failure, and no evidence of insertional oncogenesis. We did have one case of transverse myelitis that we're still following and trying to understand. So in summary, we've seen success of ex vivo gene therapy, not only for ALD, but also for MLD. And we can now report that this has been approved by the European Medical Agency, and is certainly encouraging in terms of leading to disease stabilization, reassuring safety profile. I think as Dr. Lund said, we are pretty good at getting rid of contrast enhancement and diminishing progression. We still do not know how to reverse lesions, and that always has to be kept in mind when you're considering either modality and in setting of the less score. At the same time, I want to point out there are limitations of this method. Time is brain. You need to act quickly. There are adverse events consistent with myeloablation, and there have been a few men reported who did get transplants as children and then developed AMN. So I've been for a few years now working on trying to develop gene therapy for the spinal cord as well, and thinking about what modality would be best. And here I've been coming back to the successes seen in the field of spinal muscular atrophy, particularly those with Jerry Mendel and Brian Casper successfully delivering this in infants to the spinal cord where the lower motor neuron is affected. Now, note that the lower motor neuron sits in immediate adjacency to the structures that are affected in AMN, namely the cortical spinal tract, shown here, and the dorsal columns, which sit here in the back of your spinal cord. These are the structures that transmit information from the brain down into the periphery in terms of the motor signals through the cortical spinal tracts, and some of this sensory information for balance and that is needed to come from the periphery up to the brain. So very critical structures for gait and balance that we think we can deliver to in a similar way. So what we did is we packaged the ABCD1 gene into an AAV vector, and this is work by Casey McGuire and Yi Gong, and you used an AAV9 construct where the transgene was driven by a chicken beta actin promoter. And just in short, to highlight that we got into the cells and got into the right compartment, namely the peroxisome as shown here, where catalase and ABCD1 are co-stained, showing that this really got into this little organelle within each cell, and there was able to also reduce very long chain fatty acids, as shown here in the bottom right. So we think we have good proof of concept that we can actually lead to a reduction of very long chain fatty acids. And more importantly, we can get into the right brain structures. I'll show you some more work, how we have now pursued getting into the right cell types and optimizing delivery. Here shown is an intrathecal pump that we've employed in mice and now also using in non-human primates. This increases spinal cord targeting and reduces peripheral leakage into blood. And we show a nice dose-dependent delivery across the entire spinal cord from the higher neck regions down into the lumbar regions. And we get into those cell types that are important for ALD, shown here after AAV9 green fluorescent protein administration. So this is where the green fluorescent protein is now showing all the cells that have been successfully delivered to. We then did this with the ABCD1 protein as well, and we're able to show that we got into oligodendrocytes and astrocytes, as well as some neuronal processes as well, less microglia. That was not what we would expect. And you can see also here some reduction in the very long chain fatty acids, both C26 to C22 and C24 to C22 ratios. So clearly these are just mice, and a lot of work needs to still be done to show that this works in humans. but we know that these are trials that are going to be coming our way. Just to briefly show the explosion in trials that has and approvals for gene therapy that have occurred in recent years, and we're seeing beyond SMA now also first EMA approvals for ex vivo gene therapy in Europe. I want to, in the last few minutes, point out that there are potential toxicities for both in vivo and ex vivo gene therapy. Just to mention, again, for ex vivo gene therapy, that myeloablation, meaning the chemotherapy, does lead to certain events, vomiting, infections, fever, all related to immune suppression. And something we cannot rule out, but we haven't seen with the lentiviral gene therapy so far, is the insertional mutagenesis. This has been seen in related gene therapy trials using retroviruses, but so far not in a lentiviral gene therapy trial where no leukemia or lymphoma has occurred. For in vivo AAV-mediated gene therapy, there's a lot of experience that is currently being gathered. We know that there can be some liver reactions that occur, and that using prednisolone and steroids and pre-treating the patients can overcome these. There's also some preclinical data on liver and cardiac injury, but cardiac injury in particular has not been seen in humans yet. One area of a lot of research right now is understanding how dorsal root ganglia can show transient inflammation and how meaningful that is in larger animals and humans. And again, something where I think immune modulation and using the right kinds of pretreatment with steroids and other immune modulatory drugs will be key. So just to conclude, we've shown reassuring safety data, encouraging efficacy data in the first gene therapy trials. We've now have arrived at the point of this becoming an approved drug in Europe, and hope that same will happen here in the US in the coming months. I think it's important to keep in mind that every phenotype of ALD, whether it's cerebral disease or spinal cord disease, requires different approaches. But in either way, the timing of the intervention is critical. You have to treat when early inflammation is visible, but when the lesion is not too advanced. And I think that was shown very nicely by Dr. Lund, how just a less score of 10 above and below can make a big difference. So newborn screening is clearly helping us here, and we'll be in a better place shortly. I think over time, we're going to really understand target structures and cells in ways that are going to make us more precise, more optimized in our approach. And in future, we will probably have a multimodal treatment modality for our families. So route and overall approach do make a difference. So just to close here by showing 10 years ago, I had most of my patients were coming in wheelchairs and at death's door, and now most of my children are reporting back from soccer camp, and that's really a fulfilling experience. And just to thank everybody who was involved here. This really took a village and a lot of hard work and good faith that is finally paying off. So thank you. So I think, Troy, we can start tackling some of the questions.
Yeah, we have time for a couple there. We go till 10:50, and then the next session will start. Just as a reminder, thank you to Bluebird Bio for sponsoring this. It's part of our landscape project. There'll be webinars to follow this one, and then an Ask an Experts the session, just to the audience as a reminder. Let's see, we'll take some of the high-level questions here that we can. Will there be attempts in gene therapy to correct to 100%? It's an interesting question. The field has advanced as I've watched it over 3 decades with improvements. And I'm impressed in how well we've been correcting and how well we can correct today. It's as best as it's ever been. So scientifically, I remain optimistic. Like, I wouldn't have believed where we're at if you would have asked me 15 years ago.
Yeah, I think I agree with Troy. I would at the same time caution people to think that more is always better. I think we've also, in the field of gene therapy, recognized that it's critical to hit the sweet spot, not overcorrect, not create toxicity through overexpression. And I think the most important question is what cells do we want to correct by 100%? And I think depending on the stage of the disease, the phenotype, that can be very different. And certainly seeing more correction in bone marrow cells is key. But how much correction do we want to see per cell? And how many cells in total do we want to see corrected? So those are often tricky questions. And I know Troy thinks about this a lot as well.
Agreed. Can boys who received a successful BMT or gene therapy develop cerebral disease again? I would be naive to use the word never. Like, I've not seen it in BMT, but I guess it would be naive of me to say like it can't happen. So I always say that's a possibility, even if I haven't seen it.
I've heard Patrick O'Bourg work some patients in Europe, I guess, who've had reemergence. But as you said, I think it's hard to know whether that was in our modern age a transplant experience where things have gotten more efficient.
Right. What percentage of men develop cerebral ALD as an adult, and what is the treatment? I don't. Florian, do you have a good sense of what percentage of men get cerebral disease? I just know who I see, but I couldn't give you a good percentage.
Yeah, I think we used to say it was about 20% of men across their adult lifespan develop cerebral ALD. You know, could it be a little bit higher? You know, maybe, but I would say once you've reached adulthood, the chances that you are not going to develop cerebral ALD are certainly much higher than that you will develop cerebral ALD. But remember that this risk of 20% is spread out over a much longer period than that of early childhood, where we know that 30% or 40% of those are hit.
Right. And currently the treatment for men with cerebral disease is a workup for transplant, though our criteria for entering transplant is stricter. And so men often have a lot of symptoms related to their disease and AMN. So the risk of actually dying in transplant is much, much greater. So it's still a case-by-case basis, and not every man is eligible for transplant, though some are. All right. We're notified that we've used our time for this session. It's been a great session, of course, with my colleague, Florian. And I'm reminded to tell everyone to enter the next session with Gina Cousineau. And perhaps I'll see you all back here later for the Ask the Experts session, where we can hopefully get some more of your questions. All right. Good to see you, Florian. Thank you, everyone.
Thank you.